Hi.
Hi.
Let everyone in. So that should be everybody getting ready to join. Here they all come through. Okay, well, good afternoon, everyone. Today is the Sunday, the 15th of May. Welcome to this joint TUGS emergency general surgery and hernia session on the acute management of hernia problems. I'm pleased that my co-host, Dr. Sarfaraz Baig, who's the coordinator for TUGS Hernia subcommittee, has joined me and has arranged a stellar cast of 2 speakers. So just a bit of housework to start with. We propose to do the 2 talks, and as the talks progress, if I could just remind everybody to remain muted, but you can post questions on the chat, and both myself and Sarfaraz will monitor the questions that are being posed. And then at the end of the 2 sessions, in the final 15 minutes, we will then put the questions to our panelists. So without further ado, I'm going to hand over to Sarfaraz, who will introduce our first speaker.
Hi, everyone. It's a pleasure to be co-hosting with Michael. And we have really got 2 excellent speakers on a topic which is very useful to surgeons across all fraternity and discipline. And it's on hernia emergencies. And it's a privilege to introduce Dr. Deepraj Bhandarkar. He is currently the President, Hernia Society of India, and formerly an editor, the editor of Journal of Minimal Access Surgery. He is an erudite, an academician, an excellent surgeon, and you will very soon know absolutely amazing orator to listen to. So with those words, I would like to hand over to the President and former editor of Journal of Minimal Access Surgery, Dr. Deepraj Bhandarkar, for his talk.
Am I audible?
Yes, you are now. You are now.
Okay. Yeah, so thank you very much, Sarfaraz and Michael, for this kind invitation to this TUGS session. And as Michael has said, we have only 20 minutes, so we'll go ahead with this topic. What I am proposing to do in the next 15 to 18 minutes is take an overview of the World Society of Emergency Surgery guidelines on hernia emergencies. I have no disclosures as far as this talk is concerned. When we talk about emergency repair of abdominal wall hernias, it's something that happens, every general surgeon does it. Large proportion of hernias tend to require emergency surgery. The problems that mandate the attention of the surgeon in an emergency and acute setting are incarceration, intestinal obstruction, and sometimes strangulation. They definitely carry a poorer outcome and significant morbidity as compared to a planned elective repair. Use of mesh and the type of mesh has been a subject of debate and probably will remain so. Wound infection, surgical site occurrences are far commoner in hernias which are repaired in an emergent fashion, and recurrences tend to be higher. So before we move on to the guidelines, just a brief slide or 2 about the World Society of Emergency Surgery. This was a society founded in 2007 in Bologna, and their mandate is to train and conduct CME programs in emergency surgery. Various subtopics, subspecialties have been touched upon. They also propagate clinical and basic research as well as collaborate on several multicentric trials. So in 2013, in the second conference of this particular society, they formed a consensus meeting and subsequently came out with this publication in the World Journal of Emergency Surgery. This was then modified in 2017, and several new areas, new evidence looking at aspects of emergency hernia surgery were added to this document. So the methodology of coming up with these guidelines was a fairly detailed search of the major medical databases, including Medline, Scopus, Embase, and these were the terms, fairly wide encompassing terms were used for the search. And a panel of reviewers and experts then went through these papers to come out with these guidelines. So we're going to touch upon these aspects: timing of intervention, whether laparoscopic approach is appropriate in emergency settings, how does one approach hernias in clean field or CDC class 1 surgical settings, similarly CDC class 2 and CDC class 3 and 4. Also, a couple of guidelines about the antimicrobial prophylaxis used for these cases and anesthesia. So just quickly, I'm not going to read through these, but these are the grades of recommendation that which are pretty standard and which this society has also used in coming up with the recommendation. And a quick recap on the CDC surgical wound classification: class 1 is clean, class 2 clean contaminated, class 3 is contaminated, and class 4 is dirty or infected. So let us now look at the timing of intervention. Immediate emergency repair should be performed when strangulation is suspected. Grade 1C recommendation, perhaps not surprising at all. The fine point in this is the diagnosis of strangulation. And the authors of this particular document have gone through great lengths to look at multiple papers which come up with ways to diagnose strangulation or to differentiate between an obstructed hernia and a strangulated hernia. And the SIRS, or the quartet of fever, tachycardia, abdominal rigidity, and leukocytosis can be relied upon. Contrast CT scan shows reduced wall enhancement in patients who have strangulation. Elevated lactate, CPK, or D-dimer levels also predict strangulation. So this is grade 1C recommendation. Mind you, it is important to remember that it's all these taken together which will point the surgeon to the urgency of the surgery, and no single factor can be said to be superior to any other. Is laparoscopic approach appropriate for these patients? Definitely, today we know that a diagnostic laparoscopy is a useful tool in assessing bowel viability, particularly with the advent of fluorescence angiography, or the ICG addition to the laparoscopy gives us the ability to visualize the bowel, assess its viability, and then plan the subsequent surgery. Whether one repairs the hernia laparoscopically or not in an acute setting really depends on the surgical expertise and the facilities available. But this document indicates that repair of incarcerated ventral or groin hernia may be performed by the laparoscopic approach in the absence of strangulation and a need for bowel resection. So both these require an open approach, which is safer. The other aspect that this document touches upon is a long forgotten tool of hernioscopy, which essentially means that while performing an open hernia repair, it is possible to slip a trocar into the open hernial sac, induce a pneumoperitoneum, and put in an angled laparoscope into the abdomen to visualize the viscera. This is of importance, as the authors of this paper have said, in cases where under anesthesia the bowel reduces spontaneously and one is never sure whether there is a knuckle of bowel with gangrenous or ischemic changes which has slipped inside the abdomen. You could either do a formal diagnostic laparoscopy, or hernioscopy is a trick to keep in mind in such cases. In CDC class 1 cases, repair with a synthetic mesh is recommended if the patient does not have incarceration or no signs of strangulation, and concurrent bowel resection is required. And it's a fairly high level of evidence. The recommendation is grade 1A. It is shown that by using this approach, the recurrence is far lower than if the hernia is repaired simply with sutures. I'm just going to cite a couple of studies. One was a paper by Loserivat from Thailand, and they published 2 papers. First one in 2007, and a follow-up of that paper looking at the long-term outcomes in 2013. A very small cohort of only 20 patients who underwent a Liechtenstein repair for a strangulated inguinal hernia, and only 2 patients developed wound-related issues. One was a seroma, and the other one was a superficial surgical site infections, which was managed with intravenous antibiotics. And one patient had chronic groin pain, which settled over a 4-month period. And in the long-term follow-up of up to 6 years, there were only 2 recurrences, suggesting that this approach is valid in cases with incarcerated inguinal hernias. This group looked at emergency paraumbilical hernia repair. In fact, this was a randomized trial, 41 patients, 21 randomized to the mesh group and 20 to the suture group, follow-up of 6 to 24 months. And there were no recurrences in the mesh group. There was there were 4 recurrences in the non-mesh group, and the wound-related problems were comparable. Again, indicating that emergency paraumbilical hernia repair, in this case, it was with an onlay mesh. Subsequently, there have been studies which show that if the mesh is placed in a retrorectus position, it will in fact be less prone to infection. So in emergency paraumbilical hernia repair, use of a synthetic mesh is quite valid. Let us now turn our attention to the CDC class 2 wounds. So these are patients with intestinal strangulation, and or they require a bowel resection, but there is no gross enteric spillage, there is no peritonitis. Again, in this group of patients, it has been suggested that prosthesis can be used. However, there is a caveat. In 2014, there was a meta-analysis looking at the use of mesh in strangulated inguinal hernias. And although the surgical site incidences were comparable in the suture and the mesh repairs, the authors of this meta-analysis clearly pointed out that there was not enough to suggest or make a strong recommendation for the use of mesh in the presence of strangulation or when bowel resection was going to be carried out in an emergency setting. This was a paper from Egypt looking at 60 patients with complicated large ventral hernias. And there were 2 groups. These were defects more than 10 to 12 centimeters in size that obviously could not be closed primarily in the emergency settings. And they adopted 2 ways. This was not a randomized trial, mind you. This was left to the surgeon preference. And there was either use of an inlay polypropylene mesh after having covered that gap with omentum, or by using the peritoneum of the hernial sac to provide a kind of a barrier between the mesh and the viscera. So one was an inlay polypropylene group, and the other one was repaired with IPOM with a composite mesh. The meshes were the IPOM meshes were fixed with transfacial sutures. And what they found that the surgical site occurrences as well as the recurrence were lower when composite mesh was used. Class 3 and class 4 CDC patients are the most challenging in this situation, and the decision making has to be very precise and tailored to each patient. If the patient is hemodynamically stable, not septic, and if the defect is small, less than 3 centimeters, a direct suture closure may be undertaken, or a biologic mesh may be used. If a biologic mesh is not available or is not routine in a particular center, then one could use a polyglactine or a vicryl mesh, or an open wound management could be instituted as the initial step, with a delayed repair at a later date. If, however, the patient is unstable, these are patients who are septic, are in septic shock, the best option in these patients is an open management of the wound to prevent compartment syndrome. And after stabilization, after the patient has settled, the edema has gone down, the surgeon should attempt definitive primary closure. Or it could be a staged repair with progressive, there are many modalities available now. The simplest one is a mesh which is sutured to the edges, and at each re-laparotomy, the mesh is trimmed and the facial edges are brought together. Or the other way of doing the same thing is with negative pressure wound therapy. And there are specific specialized devices available for this, which allow the fascia to be put on traction and the gap to be reduced to attain formal closure at a subsequent laparotomy. When definitive closure is not possible, or these implements are not available to a surgeon, a skin-only closure is a valid option, because here the priority is saving the patient's life and not letting him deteriorate further, not to add to the insult of the sepsis, a problem of compartment syndrome, and organ failure. So skin-only closure with the development of a large hernia, which could be tackled subsequently, remains a viable option in this group of patients. The last 2 slides, one is antimicrobial prophylaxis. The guidelines suggest that incarceration without ischemia or bowel resection only mandates a short course of prophylaxis, which typically is either a single dose or 3 doses of antibiotics. In the presence of strangulation or need for a bowel resection, that period should be extended to about 48 hours. And if there is generalized peritonitis, then antibiotic therapy. The author do not specify, but we know from experience that most surgeons would use at least 5 or perhaps up to a week-long course of antibiotics in these patients, depending on the severity of the initial insult, as well as the subsequent course as the patient settles down and comes out of the sepsis. It has been suggested that local anesthesia may be used for emergency repair of groin hernias in the absence of bowel gangrene. If there is a need to resect bowel, definitely the patient should undergo the surgery under general anesthetic. And naturally, a laparotomy for peritonitis also is safest performed with general anesthesia. So the take home from this document, the guidelines, is that the management of a common and challenging surgical emergencies has been dealt with in great detail in this document. But at the same time, the application and practice in the hands of a particular surgeon would really depend on the expertise and the experience available, as well as the resources. And it is hoped by implementation of the guidelines which we outlined, there'll be a reduction in the perioperative complication rate, as well as the long-term recurrences. Thank you very much for your kind attention.
Deepraj,
Great.
Thank you very much.
Michael, go on.
Yeah, Deepraj, thank you very much for your presentation, and most importantly for your absolutely meticulous timekeeping. I think you've clearly managed to compress everything for all of our benefits into a nice 20-minute window. So without further ado, I will move on to our next speaker. And our next speaker is Daniel Guerron. He is currently the Assistant Professor of Surgery at Duke University, completed his medical school at the Pontificia Universidad Católica del Ecuador, undertook his surgical training at the Cleveland Clinic and fellowship in advanced minimally invasive GI surgery at Duke University. He directs the research fellowship within the metabolic surgery division. He's a recognized international speaker. He's published extensively in the published literature with texts on laparoscopic, robotic, abdominal wall hernia and bariatric surgery. And he was just telling us before this meeting, he has taken up or is due to take up a new position at the Cleveland Clinic in Abu Dhabi. So without further ado, I'd like to hand over to our next speaker, Daniel Guerron.
Thank you very much for the kind introduction. I hope you can see my slides and my image well. I want to thank TUGS for the opportunity. It's quite an honor to be here sharing a little bit of this topic, which is a passion of mine. I'm going to talk about emergency hernia management. And these are my disclosures, none of which will influence my talk today. Again, we already reviewed some of the data, which is extremely helpful with that consensus. But the most important thing when you're dealing with hernias is, are you dealing with an incarceration or an strangulation? And you have the symptoms and signs. I believe that you know, the early symptoms include pain, nausea, and vomiting, and then what I classify them as late as the erythema of the hernia site and fever. Obviously, when you encounter that, you're already behind and you should be considering going to the OR for further management. When do you operate when you encounter this? For me, most importantly is the presence of pain at the site, bowel obstructions, all the signs and symptoms that we saw, and even lab values for that corroborate an intestinal necrosis. If you have bowel perforation or you have an infection of the surgical field, you got to take into account that almost 20% of all the ventral hernia are performed as an emergency operation. So it's 1 in 4, and all of us that do this are going to find this, and hopefully not often, but it's going to be present in our daily lives. The exam, especially in my field, which is bariatrics, is difficult to assess when you have an incarceration. Certainly when you have skin changes, as I said before, you're already behind. You can also use abdominal x-rays, contrast-enhanced CTs, and lab tests like the lactate CPK D-dimer, that the only reason they're here is to certify or document that you already have some sort of abdominal ischemia, in which case you need to rush to the OR. But the most important thing is, if you have pain and some patient that is not behaving well and looks sick, it is okay to go and operate. The patient characteristics are basically a patient with a female patient, minority race, older age, morbidly obese patients, patients with other comorbidities such as congestive heart failure and pulmonary disease, ascites, and in the United States, the payer status. It is important to know that the age it's crucial here. In this paper published in 2021, we see that the age of Americans that reach 65 will live another 22 years, and that will reach about 80 million people in 2040, meaning that when you put everything together, the population is aging, and a quarter of that is going to be emergent surgery. We got to be ready to deal with all these issues in our practice. When we already diagnose that and we need some other tests, what are the hernia characteristics that are going to be prompt to an emergency intervention? Is those defects that go from 2 to 7 centimeters, because the neck of that fascial defect will allow for things to go through and get trapped. And there's a very interesting paper that talks about the angles of that hernia sac in relationship with the fascia, and when it's less than 30 degrees, that would be a hernia that might present emergently. And these are things that we can actually see if the patient presents in an elective setting, and kind of like as a warning sign, we can prepare for either go quickly to the OR or be expecting an emergency change in this patient. And when we go to repair this, the main risk, these patients can be already having some systemic inflammatory response, and repairing this hernia will take us to a lot of post-op infections, higher recurrence rates, maybe infection of the implanted material, as the speaker before me just said. We have to know the classification of the wounds and know the implants that we're going to put in the belly, and also comes with an increased mortality. So emergency hernia repairs is no joke. Again, it's going to be a quarter of the operations we do for hernias, and the most important thing is trying to bring that emergency situation, if possible, to an elective setting. Why? Because we know that in expert consensus, if we work with those patients and decrease the risk with the smoking cessation, work with the BMI, and work with the diabetes, we're going to have better outcomes. So if possible, we can downgrade those patients to an elective setting. It will be better for the patient and for the doctor. Hernias is common. And this slide is just to see what are we going to do with the hernias. Are we going to do a laparoscopic, an open approach, and nowadays a robotic? The bottom line is do whatever is safe and do whatever you know best. In terms of the laparoscopic approach, as we just reviewed earlier, is not contraindicated except for one, when there's presence of intestinal necrosis. But I think that, and the data supports it, that it's better in high-risk patients because you decrease the impact of a large incision. Technical considerations include alternative entry technique. Some of these patients have associated previous procedures, so you need to master the OptiView technique, the open laparoscopic technique. You can do, in this case, gentle manipulation from the outside and from the inside, because you're going to look at that knuckle of bowel that can have some tissue changes, and also you're going to have to encounter a tedious dissection. Bottom line, if you are here laparoscopic and you are not moving forward, there's a low threshold to convert. The data suggests that most of the hernia contents are bowel, that the length of stay is prolonged in these patients, even with the laparoscopic approach, and the complications do exist, but they are less than the open approach. Just reviewing the previous paper, I think the laparoscopic repair had a 50% decrease off of overall complications at 8 weeks and decreased pain at 1 year. It is a useful tool to document the bowel viability, and the recommendation is to not do these cases where there's presence of strangulation or the need of bowel resection. Now, that's the data, real life, in my hands at least. I think less is more. Less incisions is better than the incision, a larger incision. And I deal with intestinal anastomosis on a daily basis. I feel very comfortable with that. For me, a laparoscopic approach is the approach in almost all these emergencies, unless the patient is in bad shape and needs an open operation, because will not handle the changes of the pneumoperitoneum. This is we'll start with some cases. This is a right inguinal hernia that came to our hospital with 12 hours of pain. The CT scan showed what looked like a closed loop obstruction with a lot of fluid in the sac. That is another sign for me that if I have fluid in the sac with pain, that's an immediate operation. I opted to do a laparoscopic approach so I can take a look at the bowel. Sometimes when this reduce under induction, you don't know what's the status of the bowel, so I always put a camera. In this case, we opted to do a combined laparoscopic case to assess for the bowel, and then we perform an open hernia repair with mesh. Some people will argue that you can do this laparoscopically. In this case, we opted to do an open repair because of all that free fluid. This is a thing that I encounter most of the time. My name is associated with bariatrics, so I get BMIs greater than 40 most of the time. In this case, this lady had a prior ventral hernia repair with multiple operations, came here with a large bowel obstruction reduction, and then the decision in the OR was to go ahead and do the dissection, try to save that colon, get it out of the hernia defect. And then the dilemma was to do mesh or no mesh and how we're going to close it. What we opted to do was to do a resection of that, a small incision on top of the hernia sac, dissect the hernia sac and close it primarily. Because when we ran our risk scores using the NSQIP calculator, we see that there was a 20% any complication rate, serious complications rate of 52%, combined with a higher BMI. We thought that the best way to do it was to temporize that hernia, close it as best as we could, and then get out and come back another day to fight a battle once the patient is optimized, perhaps with a lower BMI after bariatric surgery, in which case we can have a formal repair for this patient. Next, very interesting, not only congenital or post-op surgeries occur, you can have Richter hernias, which is just a partial thickness bowel incarceration through a port site. This is a case of and it's interesting, I bring it because traditionally we think that 12 or 15 ports are only the ports that get this problem. In here, an 8mm port from a robotic case got an incarceration, and the patient presented a week after his inguinal hernia repair with a bowel obstruction. And we were able to put another camera, and we found this in a very, very small hole of an 8mm hole. We were able to reduce the hernia, assess the viability of the bowel, and carry on with our lives without any resections. That hole was closed primarily because it was less than 3 centimeters. This is another case back in Ecuador. After a bypass, 3 days later, the port side started leaking some purulent fluid. A CT scan showed contrast going through that port side. And we took the patient back to the OR, and we found another Richter hernia that unfortunately already perforated and was leaking enteral contents into the skin. And here we see how we are addressing. We're trying to reduce, and we find the hole. And this is why laparoscopy is so useful, because you can actually see and assess and perhaps intervene in these situations in which you have already enterotomies. And perhaps if you want to do it, you do a resection. As I said earlier, I feel very comfortable doing resections in the abdomen. The guideline says that perhaps this is not the best idea and you should continue with something open, but there's nothing wrong on enlarging the port side, exteriorizing that valve that you already identify in the belly, and do a formal repair outside. In terms of an open approach, again, the indication is the same. If you need an operation, you need an operation. The techniques can be, as reported earlier, a primary closure or using of mesh. I believe the retrorectus space is the best space because it's well vascularized, and there's nothing wrong if you can, and the patient is healthy enough to do a component separation if you need to. But if you cannot, you can always do an onlay repair. This is a case of a congenital umbilical hernia that presents as an emergency, and I will show the video in a little bit. But also, I'm not going to go into cirrhotics and umbilical hernias because it's a different topic that we can have for another webinar by itself. But you typically see patients that have changes at the skin at this level, and you have compromised bowel. In this case, a patient came to us with incarcerated, strangulated bowel. And we opted to do an open repair with a resection there. And then we did a primary repair without mesh, and we placed a negative pressure wound dressing in order to control the ascites. Another case, this was a case that I got, it was in the middle of the night. I got a phone call from I got a text message from the resident showing me the CT scan. And I was thinking, how can I temporize this? Is a cirrhotic, maybe a paracentesis, maybe drop an NG tube for decompression. But then the next picture was this picture here. So you can see that the skin changes were rather advanced. The skin was paper thin, almost eroding into the bowel. So we have to go to the OR, and we opted to do an open repair, check the viability of the bowel, I'm sorry, and close the fascia without mesh. Lastly, inguinal hernias. If an elective setting, I have a large inguinal scrotal, my go-to will be a robotic approach because I can reduce the hernia and close that hole with mesh. But in the emergency setting, I prefer to do an open repair because I can control the sac and I can assess the availability of the bowel. Plus, I can put permanent mesh if needed. This is the case I was talking about, a large lady with a loss of domain and came to us with profound anemia. Most of her organs were in the sac, but the most important thing was the spleen was ruptured, and she was bleeding several liters of blood into her belly. So we optimized her for 3 days with transfusions, and then we consented her for a component separation. I'm gonna go forward this video, but entering the belly and controlling that spleen that was ruptured in the hernia sac. I believe this is a case that we published back in 2015. We did the splenectomy, then we reduced all the bowel back into the cavity, and as you can see, the hernia is huge. We have no options to perform a component separation with either a dissection of the retrorectus plane. And as you know, the TAR is an extension of the Reeves-Stopa procedure. Once we delineated our anatomy, looking at the neurovascular planes, we proceeded to do the release. As you can see here, we're dissecting the transversus abdominis. Again, not quite an emergency in the middle of the night, but presented as an emergency. And as I said earlier, the key is try to convert an emergency into an elective case as much as possible. We continue with the other side. We continue doing our dissection and the division of the transversus abdominis on the other side. We proceeded to dissect the linea alba, close the hernia sac, and as you're going to see in a second, the hernia was so big that we opted to sew together 4 pieces of mesh in order to do adequate coverage. Once the mesh was inside, we secured with 8 points, 1 at the xiphoid, 1 at the symphysis, one at the Cooper's ligament, and then 3 laterals on each side. Using transfascial sutures. We left 2 closed suction drains, and then we proceeded to close the fascia that unfortunately we could approximate most like 70% of the fascia, but we were left with a little gap in the middle. And as was reported earlier, it's okay to just cover it with the skin if you have issues with the repair. We touched on this earlier about the recs on the use of mesh. My take-home message is if you have a wound class 1 or 2, it's okay to use synthetic material. If you have a wound class beyond 2, meaning 3 or 4, you should consider using a biologic mesh or some polygalactic mesh. My preference is to use polygalactin because of the cost of the biologic mesh. Obviously, this patient needs to be advised that we are accepting a hernia and there's a new procedure coming up. But the important thing was to temporize and turning an emergency situation into an elective situation. definite fascial closure is not possible, you can use the skin, you can use biologic bridges, you can use wound bags to manage it. And the other thing is that component separation technique may be useful and a low-cost option. The best thing that I can tell you in the management of emergencies is the laparoscopic approach is my go-to approach, because it gives me a lot, if I have a healthy enough patient, it gives me access to the abdomen, it gives me access to reduction, it gives me access to assessment of the viability of the bowel, and give me access to put mesh in an IPON fashion or in the inguinal myopectineal orifice. I feel very comfortable with it, but the bottom line is, if you feel comfortable doing an open repair, go for the open repair. I wish everybody could get a little elective hernia from now on, but be careful on these things. It's a quarter of our practice is going to be emergent surgeries. We have to be ready. As we just reviewed, laparoscopy is an important tool, and there is some data that help us to use different prosthetic materials to cover these issues. With that, I want to thank everybody again for the opportunity, and I'm happy to take questions.
Thank you so much, Daniel. That was an excellent presentation. Sarfaraz, do you want to kick off with the couple of questions that we've had posted?
Yeah, I think it was an amazing talk, both by Dr. Deepraj and Daniel. And I think I, for one, benefited a lot by hearing so many things reinforced. Let me take the questions by Dr. Adnan up there. And his question is there a place for manual reduction under sedation for incarcerated hernia? Dr. Deepraj, would you like to take that?
Yes. So yes, there is a place for manual reduction, particularly in the incarcerated groin hernias. In fact, there was a paper, I think, last year, sometimes in the journal Hernia from Andrew Dubow's group, and they talked about doing a manual reduction under anesthesia or under sedation with either fentanyl or morphine and benzodiazepines. And I remember the sort of acronym that they'd used for that type of reduction or taxes. They said it should follow the principles of GPS. So it's a nice mnemonic to remember. They said it should be gentle, it should be prepared, and it should be safe. So you should assess that you're not trying to reduce a strangulated hernia, not be pretty sure of that. But yes, there is a place for gentle taxes in patients with inguinal hernia when they present you, and then the subsequent surgery can be done either in the same admission or a few weeks later.
Yeah. So Daniel, this one probably could tell us here. Dr. Adnan has a second question, which I think is a very valid question. For open femoral hernia repair for strangulation, which approach is recommended? So for a strangulated femoral hernia, Daniel, which one do you do?
Thank you. Yes, very good question. So it's kind of a sad remark I'm going to say. You know, younger surgeons do not have the luxury to learn tissue repairs that often, particularly in the United States. The traditional question will be to do a McVeigh repair to reduce that femoral hernia. However, for us in our practice, we do prefer the laparoscopic approach because we can reduce that hernia, access the myopectineal orifice, assess the situation there, and do a combination of things. So if we have a necrotic bowel, we can do a resection and then temporize the repair as we can, or go open. But in my hands, I think the best way to do it is to do a reduction laparoscopically and then fix the hernia that way. I have access to the bowel, and I don't have to struggle remembering the technique of the McVeigh or other techniques. I feel much more comfortable with the TAP approach So I don't know if it's good or bad, but the open approaches are a dying, hopefully not a dying practice, but I always tell trainees, please learn at least one open approach to do with this. But bottom line is a laparoscopic approach will be my go-to.
I think that's an excellent answer. I'm a UK trained surgeon, 3 years post residency, and I still get, and here's a Scottish phrase for you, I still get the heebie-jeebies for the incarcerated femoral hernia, because I just hadn't seen a lot of them. And you know, you're always taught McEvedy or a high McEvedy approach. It's a lot more difficult than it looks. And I certainly have find it much easier to go in laparoscopically and bring these and reduce them. I think there's a lot of advantages to have a look at the bowel, but certainly I think the art of the McEvedy in the current minimally invasive environment that we have has been lost. And it's certainly, I've done it a few times, but it's a quick look on YouTube to remind me how to do it, I have to say.
So I have sorry to expand a little bit. I was on call, and one of our ACS surgeons got one of these femorals, so they started open. They called me to fix it. I looked at it, and you know, morbidly obese patient, you couldn't find the inguinal ligament. It was not, so what I did is I whip stitched the skin and went back lap, so I can check all the bowel, check at the myopectineal orifice, patch it from there, and then repair the skin. Because I feel more comfortable doing the laparoscopic approach than the open approach. Sad or not, I think it's laparoscopy in this case is win.
Yeah.
Deepraj, can I invite you to make a comment on that, because you may have a different perspective?
No, I agree with both of you that yes, my go-to today would be a laparoscopic. If I had to choose an inguinal, or if a surgeon had to choose an open approach, if he felt uncomfortable doing this by laparoscopy, perhaps an inguinal approach, which most of us are familiar with for an inguinal hernia, Liechtenstein, would probably be the way to go. Open the transalis fascia and have a look at the femoral ring. If a resection is required, it can still be done through an inguinal approach. But my go-to would be a laparoscopy in this situation.
Yeah.
Thank you.
I think, yes.
Sarfaraz, sorry.
Yeah, just to, yeah, no, not at all, Michael. I just thought that, you know, for a femoral hernia, agree with everyone, you know, because it's so much easier to do a laparoscopy, see the entire extent, do the same surgery that we do for, you know, a TAPP for other groin hernias electively. So it's a much easier thing to do rather than struggling at that space with the strangulation. The only issue sometimes could be if there is a dilated bowel, then it may spoil the party out there for laparoscopy. But I think more often than not, it is still manageable. Let's look at the other questions here.
Sarfaraz, I've had a quick look. So there's 2 questions on relatively novel hernia adjuncts. So the one is the role of ICG in the emergency setting. I've got no experience with it. I do have some experience of Botox, but not in the emergency setting. So what do our panelists have to? We'll tackle both at once. Any experience with ICG?
Yes, we have used ICG in the setting of incarcerated paraumbilical or abdominal wall hernias, not so much in the inguinals. And after reducing the contents from the hernial sac, we always prefer to use the ICG to confirm the vascularity of the bowel, spend our time, oxygenate the patient, even put some hot gauze pieces inside on the bowel, wait for 5 minutes, confirm that the bowel is viable before planning the repair. So yes, we have used ICG in ventrals in an emergency setting. Botox, I have never used it in an emergency setting, but I remember about 3 or 4 years back during one of the SAGES meeting, there was a presentation, I think from Todd Henniford's group, on the use of Botox in an emergency setting to relax the muscles. And in fact, that is probably the first time I had heard the word chemical component separation. Dan will probably be able to add more to this.
Yes, so first with the ICG, I think is a phenomenal tool. I think it gives you a lot of details in terms of the perfusion of the tissue, and gives you more hints if you need to do a resection, if you don't see a good, nice green color. I think it's an excellent tool. We use it to assess the availability of the valve. We'll still use, Doppler and stuff like that to check the availability. And as you said, put some warm compresses. I doubt we do resections. The only problem that we have is that you sometimes need different towers with different cameras. And in an emergency setting in the middle of the night, you need a whole, team to know what they're doing, and it's not their normal routine. So it's a little bit troublesome to do that. But I think it's a phenomenal tool. In terms of emergency Botox, so the only thing that you need to consider is that to have the full effect of that, you need anywhere between 5 to 7 days. So going back to what I was just saying in my talk, is if you have the luxury of converting that emergency into a somewhat elective case, you can use that chemical component separation, but you need to think about, how am I going to temporize this bowel for 5 to 7 days? Because that is the optimal time in which the effects of the Botox to relax the abdominal wall will take place. So in the emergency, in the heat of battle, in the middle of the night, I don't think there's a role. Because if you are in dire straits, I think you can do resections and do closures and do bridgings and do stuff like that and get out of Dodge and accept the hernia. Because that's the main important thing, is accepting the hernia, accepting that you need to come back to a fight in another day. So it might be useful, but in the emergency setting, I think it's not, useful. Now, if you can temporize that, it will certainly help you to correct and finalize the procedure for a patient.
And just, well, from my point, I do major trauma as well. And it's illogical to me in the genuinely physiological compromised patient to prolong your operative time. You will have a poorer outcome. And for me, not many people are used to using Botox, and therefore trying to do it at 2 or 3 o'clock in the morning sounds like a recipe for disaster.
Yes, and if you see in Dr. Hennifer's talk, they use the radiologist actually to go and do 3 injections at 3 different sites, 300 units of Botox. So it's the resources for that are tremendous. So again, if you can, so going back to one of the questions of reducing the hernia, I reduce it if I have time and the patient is stable, right? If I don't have elevated D-dimer, CPK, lactates, it can be done and you can observe, because I'm downgrading that patient. But as you said, the resources, and if the patient is sick, I don't think there's a role for that.
We had another question about the role of laparoscopy in emergency setting and its impact on intra-abdominal pressure and compromising blood supply to the bowel. Who wants to tackle that mammoth subject?
Me? So yeah, so the contraindication for the laparoscopy is the patient is unstable and is not gonna endure the elevation of the intra-abdominal contents and the decrement of the blood return. So if anesthesia is not giving you the luxury of putting a scope, you shouldn't do it. I personally, if they allow me and the physiology of the patient allows me, I always put a scope in. Perhaps because I have that training, because I feel comfortable. And in doubt, and when I do the pneumo and all the physiology kind of starts going south, then you stop and you open. That would be my take. So I will always favor laparoscopy if anesthesia and the physiology allows me.
I think more than the increased intra-abdominal pressure causing compromise in the bowel supply, I would be worried about getting the first port in safely. If the abdomen is grossly distended, if you're worried that the act of even putting a Veress needle at the Palmer's point or getting the first port in is likely to damage bowel, I would open right away. I mean, the CT scan should give you a clear idea of whether you're going to have access for even the first port. and then subsequently getting 2 more ports in to safely run the bowel from one end to the other.
I totally agree. And that's what I was, as you said, sir, the Palmer's point and all that, going blind with needles, we can go back to the old techniques, or I don't know, at least in my practice, it was old. When I was a resident, we used to do Hassan techniques, which is an open technique. Now we do OptiView. So if you still want to, if you think that the bowel is dilated or things like that, there's nothing wrong to go and do a Hassan open technique to introduce a port and a camera. I agree with you 100%.
I'd like to pose a question to our 2 speakers. Daniel, you touched on negative pressure wound therapy. Is that something that you use routinely, particularly in the obese comorbid patient with emergency hernia surgery that's got a high risk of wound infection?
Depends on the wound class. So if I have something more than a 2, I go and put a negative pressure wound back just to be safe, because the morbidity of a tall panis is terrible. But if I have a clean case that goes, up to a wound class 2, I tend just to close primarily without any issues.
Thank you.
So, Michael, can I shoot a question before we take a few? Yeah. So, Daniel, I saw in one of your cases in an emergency, you did resort to component separation technique, TAR, in that emergency situation. Somehow I feel that component separation technique is it's a little bit of a challenge in emergent situations. So would you clarify why and when would you do it, and what would be the words of caution in using CSTs in these hernia emergencies?
Very good question. So that was the reason why I put that video, because we resolved an emergency situation. So the patient came emergently, but we ended up downgrading into some sort of an elective setting. There's data that you can do component separations if you want in emergency settings, but as Michael said, you have a patient that is sick, you need to get in and get out as safely as possible. So unless you have a very, very, very good reason to perform a component separation and all the stars are aligned, meaning you don't have dead bowel, the patient is okay, then you can do a component separation. I personally would not do it. I think that only if you're a true expert in component separations, there's a role. It's a technique that you can get in trouble very easily. And you don't have time. So, in this case, I was with Michael Rosen, which was, one of my preceptors there. So we were pretty safe. I was a 5th-year resident, so it was okay to do it. I personally have never done it. If I need to do some sort of component separation just to close the fascia, my algorithm will be bridge. If I cannot bridge, so close primarily. If I cannot do that, I will bridge. And if I absolutely need to do it, I much rather do something exterior or an anterior component separation, because then I save my last bullet, which will be a posterior component separation for a later day.
Very wise.
I just was going to ask you that. And may I take this opportunity to ask you, what kind of bridging repair would you do? What kind of mesh do you take when you do these bad cases?
I don't have much data to back up this, but I have to apologize. That will be my personal opinion. I think that putting a piece of prosthetic that costs more than the surgery and the hospitalization, meaning like $20,000-$30,000 of a prosthetic there, is not worth it. So in that case, I will err for a Vicryl polyglactin type of mesh. But that is, it's just philosophy. I know that a biologic mesh will work better.
Yeah.
But it's just, $30,000 piece of mesh is just a lot of money.
Okay, so just in the interest of time, 2 last questions were posed. So one to Deepraj, how long do you wait after you use the ICG before you make your final assessment on viability of bowel?
The ICG in this setting would appear in the bowel within in less than a minute. So you would take the ICG, dilute it with 10 ml of saline and inject about half of that. And within a minute or two, you would have the bowel lighting up and giving an idea of the vascularity. When we use it for the delineation of the biliary tree, one needs to wait for at least about an hour or so before it gets excreted in the bile. But in terms of vascular assessment, it's almost immediate.
Okay, and the final question I'll ask Daniel, can we delay mesh implantation by, for example, 5 days to reduce the risk of mesh infection in a contaminated field?
Yes, you can. There's data that also adds some antibiotic therapy while you're waiting. My question is, if you have the luxury to wait for 5 days, why don't you just wait until you optimize that patient?
I think that sounds like the perfect answer. And on that note, I'll draw the session to a close. I think so. I'll start off by thanking Sarfaraz for working with me on this session. He did all of the, well, I think it's fair to say he did most of the hard work. He invited the speakers, used his international connections. And I think we've had, well, I've personally learned a lot today. I will change a couple of things in my own practice. I want to thank the 2 speakers for taking the time on a Sunday away from their family to give us their pearls of wisdom. I personally have enjoyed it, not just because it's my session, but thank you to our 2 speakers, and I'll hand over to Sarfaraz for a final words.
Well, thank you very much, Michael. It was a pleasure working with you, and it was an absolute delight to have Dr. Deepraj and Dr. Daniel, and it was great to listen to you. And I think the kind of excitement in the chat box also suggested that people found this useful. Thank you, Daniel. Thank you, Dr. Deepraj, for this wonderful time that you gave us. And we hope to dig back to you again in the future for some sessions like this.
And we're only 1 minute over our scheduled time, and we're going to step aside for our TUGS African brother and sisters to come and do their session. I'll draw the meeting to a close. Thank you so much.
Bye. Thank you.
Bye-bye.